Salam alaikum. Good evening, everybody. This is Mani Chandran here. I'm one of the geriatric psychiatrists working along with Dr. Hanadi and team. It's my esteemed privilege to be here in the nursing webinar platform, sharing with you on a very important area of dementia, which is the behavioral and psychological symptoms of dementia. The talk title, I've kept it as Feeding the Pigeons by Lakeside. I have no conflicts of interest to declare. So let's get going. So what are we going to learn over this approximately 30 minutes? We'll try to understand what are the behavioral and psychological symptoms, understand the evidence base on evaluation and management of PPSD. We will try to understand the emphasis and the importance of the person-centered care in the management of PPSD. And together we will learn all this through an interesting life case scenario. Looking back a century ahead, if you look, the clinical transcript that we have from Alois Alzheimer on the patient Augusta D. Quite striking if you read through it. The first symptom the 51-year-old woman showed was the idea that she was jealous of her husband. Soon she developed a rapid loss of memory. She was disoriented to her house, carried things from one place to another, and hid them. Sometimes she thought somebody was trying to kill her and started to cry loudly. This transcript, which sort of typifies the behavioral and psychological symptoms of dementia from the first case that many years back, till date, dementia with PPSD comes with all these very similar presentations. Centuries on, clinical science remains the same. So what is BPSD? The definition, as from the International Psychogeriatric Association Consensus Group, they define BPSD as a symptom of disturbed perception, thought content, mood, or behavior that frequently occur in patients with dementia. You have a behavioral component of it and you have a psychological component of it. As the slide highlights, the behavioral component is what we observe. So it is the objectivity. And the psychological component, how we capture, is through interview-based. So why are we talking about BPSD here? No learning session of dementia is complete if we don't touch on BPSD. And why is that? I mean, all these, information out there, which we have highlighted in this slide, highlights the significance of BPSD. What stands out is, BPSD is an integral part of the disease process of dementia. And it is this one component which has the maximum impact on the family and caregivers. So thereby, the more that we need to know and understand how we manage. We'll just try to look at few research papers as to how they have looked at BPSD. So this one is on BPSD symptom cluster. This looked at, before the dementia diagnosis and post-dementia diagnosis from a timeline perspective. And as you can see, approximately 30 months before the symptom diagnosis, you are having behavioral symptoms of depression, social withdrawal. And towards the later part, which is, post-diagnosis, you're getting the symptoms of aggression, hallucinations, wandering, and related symptoms. So someone may ask how prevalent it is. Well, these two papers are landmark papers that identifies the significance and the prevalence of it. The Cache County study says 97% of subjects with dementia had one BPSD when followed over 5 years. So quite prevalent. This is another meta-analysis which tells us the description of the symptom profile, again highlighting the prevalence of apathy and depression and aggression being much more compared to disinhibition and hallucination. So what are the theories? Why should we look at theories? Theories help us to understand why it is happening. And more equally and more important, it helps us in our management approach. So there are four theories which have come to support BPSD. First, we have the biological theory, that the symptoms stem from a neurological change in the brain. The behavioral theory, which says behaviors controlled by antecedent and the consequences that follows. Then we have the story of a theory of reduced stress threshold. And the fourth, which is again equally important, is the unmet need. Patients with dementia, they are not able to communicate like you and me, and they have a need, be it hunger, be it thirst. And it is a behavior that is communicating. So because they are not able to communicate, the unmet need. So those are the theories that we have. Now, looking into the basics of assessment. So say you're in the ward, you've got patients with dementia, there are behavioral concerns. When you start the assessment, what are the essential things that you should have in your list? So these are sort of what we will call is the 5 pillars of assessment of PPSD. First is you have to look at the symptom. We need to understand it's not just agitation or aggression. We need to look into the depth of it. What is the type? What is the frequency? What is the severity? What is the pattern? What is the context? What is the timing? One of the objective assessment tools that will help you in the process is the neuropsychiatric inventory or even the Behave AD. Then we have to evaluate the risk. What is the risk of harm to self or others? Another important thing which we should never miss out, 2/3 of patients with dementia can have delirium. And the last thing you want is, we leave it. This is a behavioral problem in dementia when it is actually delirium. That is serious concern because delirium carries fatality. So, always suspect is whenever there is a first time PPSD happening, suspect, is it a new onset PPSD, is it a delirium? Precipitating factor, look at the medical factors, the common that we find in our elderly: constipation, UTI, medication related and associated medical conditions. Sorry. And then, of course, you look at the modifiable factors. When you're looking at the modifiable factors, you look at the holistic picture. So you can have the patient-related factors, which again, it can be the unmet need, it can be the medical condition, it can be the pain, it can be the sensory limitation. You have the caregiver-related. Caregiver-related, it can be caregiver burden, which is adding to the manifestation, the lack of education, their inability to understand what is going on, adding to the picture. Then, of course, you have the environment. Again, environment, it can be overstimulating. Often we come across when we go into the home visit, they say Papa becomes more agitated when there is a lot of families coming over, particularly more children come and they are making noise. So overstimulation, understimulation, lack of activity, boredom, lack of structural routines. So all these are environmental factors. So we have to understand these are modifiable factors. These are something you and me can do to change for the betterment. Okay, moving on. I will just request my secretary, Mr. Saleh, please keep a track on time. So when I'm just about 10 minutes before, please let me know. Okay, so what is the mantra that we have to follow? We have to have something when we are evaluating BPSD. We have to have a strategy how we are evaluating BPSD. And the strategy that we follow is the DICE approach, time-tested, well-established. As it stands, describe, investigate, create, and evaluate. We will learn this through a patient, real life scenario. Whenever I'm asked to talk about PPSD, time and again, I go back to this patient. I'm extremely privileged to being able to have the opportunity to look after this gentleman, because it has helped us to learn so much and reinforce our belief in the beauty of medical science. So I'll take you through this. So this is, of course, the case that a patient that I looked after, not whilst here, this was whilst I was working in England. So the story is this. So I'm called out to one of the nursing care homes on a late evening of the weekend beginning, which is Friday evening, approximately 4:30. So I'm called by the senior manager of, and this is a secured long-term care setting, and it is a crisis call. And they said it is related to a new resident who has just moved in 3 days before, 70-year-old gentleman whom, for the purposes of presentation, we will call as Mr. S. Now, what is striking, it is quite vivid to me even to the date. When I walk in through the door of the care home, what do I get? I have a senior manager. I have 2 of her deputies. I have 5 of the nurses who are straight running to me, and they are holding set of papers. And straight, what do they say? We will call the ambulance, and can you take him to your locked psychiatric ward now? This is all dementia. They go on to say, I have been a manager in this long-term setting for 10 years, working over for 20 years. I have never come across anything like this in my working career. In the last 72 hours, they go on, we have filled 70 incident forms, which is, similar to our OVA. Before you initiate any further questions, the desk phone starts ringing. And there, they are giving me the phone to speak. It's a physician of the care home who's calling on the desk phone. And what does he say? Wherever in the country you get a bed, move him now. So this is what I'm facing to. And then they go on to read the incident forms: kicking staff, punching staff, banging doors, throwing chairs. They go on to say, we nearly got him this morning. He tried to take a chair and throw through the glass window. And the list goes on. Well, in any assessment, the first step always is to collect information. Okay. So yes, I heard what the team there, who were quite distraught, and shared with me. Then I go through the background information. And quickly, what comes to my attention? 70-year-old Mr. S is well known to the local memory services. He has a well-established diagnosis of dementia, of Alzheimer's type. He is on treatment, on rivastigmine. And the other important information is he has been living alone. Meaning before he came to the care home, he was living alone, supported by visits from his family. And it was approximately 5 weeks preceding my assessment that he actually had a fall in the bus stop. And then he was taken to the acute medical unit. And from the acute medical unit, there was a pre-discharge meeting, and it was deemed that he's not safe to go back home. And they decided to keep him in a care home setting. And what we understand is actually from the medical unit, before coming to this care home where I was assessing him, before coming to that, he had actually gone to another care home. But that particular care home, it did not have secure doors. So he actually went out and he went missing. And after 3 hours, when police found him approximately 4 miles away from the unit, he was walking in a cold winter day, not knowing where he's going. He was not able to converse and say what he wanted and where he was going. And that is when the authorities decided that he has to move into a secure nursing care setting. And that is where he was brought in. And that is where I was assessing him that evening. So I got some background information. Then I said, okay, I've got information. I would like to see him. And what strikes me, and this is what I always say, the beauty of medical science, what you heard all the before and what you see. What do you see? And today also, this evening, that picture is vivid in my mind. A smartly dressed, moderate built elderly gentleman sitting in the foyer area of the care home, comfortably browsing the newspaper of the day. And when I do the mental state examination, he's pleasant, he's alert, he is communicative, but his communication is limited in that there is word finding difficulty. There are cognitive limitations evident, but I could not elicit any depression, any psychosis, and more importantly, I could not elicit any restlessness, any agitation, any anxiety. Comfortably, he's sitting and browsing through the newspaper. Now, you can see what all I heard before and what I'm seeing. Whilst I'm seeing that, they come back on me. Doc, this is not how he is. See all these incident forms and they're waving behind me. We are not keeping him. 5 of my staff are off work. We can't take it anymore. Can you take him now? Okay, well, today we are having it as a webinar. If it was a face-to-face, definitely I would have walked through each one of you and looked at the pros and cons of each of these options. Of course, you will know what we did, but this would have been, if it was a face-to-face, I would have gone detail into it. Now, having looked at what we heard, what we saw, what should be your first step? Again, a question to ponder. While we are pondering on that, again, the communication from the other side is transfer to locked psychiatric ward. Well, should I just get an ambulance and move him over there? 70 incident form, staff going off sick, everybody quite distraught. So all these are thoughts. We would have discussed it more if it was face to face, but let me go into how we are approaching. So we are approaching, as I said, we have to have a strategy, and the strategy that we follow in the PPST management is DICE: describe, investigate, create, and evaluate. So how should I go about the DICE steps? Should I go through the incident forms? Should I scan through the incident forms? Should I learn through the incident forms? And even if I'm going through the forms, what should I be looking for? Okay. So what does DICE say? The D of the DICE says describe. So I should go through the incident forms. The answer is yes. I should be looking at the incident forms. I should be looking at what is the type of the behavioral, what is the frequency of the behavioral symptom, what is the severity, what is the context, what is the timing, what are the triggers. So this is what I have to learn from the incident forms. And the moment I start glancing through it, it was quite evident to me. There was a pattern coming to it. Beauty of medical science. Now, before I go into back to my patient, I will just briefly touch on what is the available evidence base with reference to BPST. So, ladies and gentlemen, one take-home message: BPST management, the first line, inevitably, non-pharmacological interventions are universally recommended as the first line management of BPST. It's not that I get a call and I say, okay, dash in with 10 milligram IM haloperidol. Sorry. First approach is non-pharmacological, not medication. There are multiple strategies on non-pharmacological, as these slides highlight. Person-centered care, communication skills, adaptive dementia care mapping, so, different therapeutic interventions. When you look at it from a pharmacological point of view, yes, pharmacology has a role, but that role comes mainly one has been unresponsive to the non-pharmacological approach, and we feel that the risk scenario is becoming higher. There, yes, antipsychotics have a role, particularly the atypical antipsychotics, more so it is on the risperidone. But again, the important message that you have to take is, if I'm going with that prescription, I have a duty to look at what are the pros and cons. I have a duty to discuss with the family member the pros and cons, the side effect, potential side effects, in particular, the risk of stroke and the cardiac impact. I'm not going through the details of the medication, the dosing, those things, we can do in another session. Owing to time aspect, I'm not focusing on the pharmacological side. So there are other agents, other molecules as well, anticonvulsants, low dose of antidepressants. Let's get back to our patient. So what do I find? So I go with the D, which is the describe, and I'm going, and the investigation. And in that, I'm looking at all these parameters. And as I told you, there is a pattern to it. So what do I find? Now, this is the beauty. See here, when you scan through those incident forms, 70 odd, what do you find? Barring 5 incidents of agitation in the evening, majority of the significant behavioral symptoms of aggression and agitation was in the morning, approximately between the hours of 9 and 11. Rest of the periods, he's calm. What time I'm there in the care home? Approximately 4:35 in the evening. What do I find him? Sitting and browsing through a newspaper. But what did I hear? All those incidents. But what do I find in the pattern? Incidents have a time. They are happening in the morning. When you look at the previous care home where he went missing, what was the time? 9:30 in the morning. The more you're looking into, something is coming up. There is something happening in the morning. How do you proceed now? Okay, you need more information. While you are trying to get information from there, they are calling, Doc, can you confirm the transfer to the locked psychiatry ward? Can we call the ambulance? So you are doing your assessment, but out there, this is what is happening. But you have to remain focused because you have seen something, you have heard something. What you have heard and what you have seen is not matching. So you have to learn more. You have to understand what is going on. So again, these all is happening. They want to call the ambulance. So coming back to the patient. So why mornings predominantly? So that is the burning question in our mind. What do I do? Before I do anything, I have to just remind one very important aspect to you all. In BPSD management, please remember, even if you forget the 10 milligram IM haloperidol, remember this: person-centered care, the essence and the importance of person-centered care and behavioral management. The human value of the person living with dementia, the individuality of the person living with dementia, the likes and dislikes of the person living with dementia, the importance of the person's perspective, the importance of the relationship interaction, and who the person is behind the dementia. That is what we have to understand. Okay, so how do I go about? Pick up the phone, it's late evening, doesn't matter. I have to solve and understand the situation because the team there is in distraught. I call the daughter. The moment I start speaking to the daughter, the family straight away interrupt. The moment I say, I've come from this and such place and I'm calling from such and such place. Doc, we have to change this home. Yesterday evening, he was very unsteady. They pumped in Promazine on him. Promazine is one of the older generation, typical antipsychotic, carries a high risk of postural hypotension. Move him to another care unit. He is the most caring person we know. He doesn't deserve this. And now the care home is saying psychiatry ward. No way. So family want him to be moved because they feel the care in the existing care home is not in the right approach, not in the right attitude. It is medication, psychiatry, moving to psychiatric ward. This is all what they are hearing. So that is their concern. Okay. But of course, we listen to their concern and then we try to understand more. Okay, I've heard them. Tell me, what is the gentleman's typical day? Tell me, what is his like? What is his dislike? And what do I get? This is a transcript of that evening's telephone call with the patient's doctor. And let's read through it because this is where the essence of medical science lies. The call transcript says, nicest person you could have ever met. He's a very caring, always helpful. He served in the government services, retired at the age of 65. Mom passed away, which is his wife, sadly passed away 2 years back. And his dementia has been there and we support and manage him, but he has been reluctant to move away from his own house since his wife passed away. So what is his typical day like? Well, every morning, so there is a care package. So the carer comes in the morning, he opens the door, carer helps him with breakfast and medication because they have a, medication box through which they are able to take the medicine and give it. And what happens after that? Dad goes alone for his outing. Yes, he loves going out, Doc. He takes the number 72, which is the local bus. He gets down by the lakeside and he feeds the pigeons. Then he goes to his other daughter's house, which is by the lakeside, spends time there, and evening, that daughter drops him back at home. This is his routine until, unfortunately, 5 weeks preceding our assessment, when he had the tumble and the fall in the bus stop, that he had to be rushed to the hospital. And from there, all the care home aspect happened. So you can see A lot of information comes from that, which gives us a description of the person behind dementia. Go back to the drawing board. We get back to the incident forms, get it back. You're trying to refresh and look at it again. You speak to the staff. So what is happening? What is the context? What is the site of these agitation and aggression? When you look at it, majority is happening in morning, as I mentioned, and the site where it is happening, it is on the exit door. Agitation, aggression, staff is closing the door, and the more he is getting agitated, predominant is there. Evening incidents, as I told you, bearing 5, which is mostly when his family sometimes visits in the evening, when they're going out, is when he was having those few evening incidents. Majority is in the door area. Well, we have looked at it, we have described, we have investigated. Now we have to create a plan. So what is the plan we are going to create? Because we have established that his morning has to be his outing. His outing has to be his lakeside. His outing has to have the component of feeding pigeons by the lakeside. So we create that. We made the case that, okay, for the first week, he can continue to stay in the care home where he is, but give him a carer who comes in the morning, takes him on the bus to the place where he goes by the lakeside to feed the pigeons. We set it up. It went successful. 1 week, no issues, no incidents. So thereafter, what we do? We got the local authorities to set up a carer, regular daytime carer, because, evening, his family is able to come and be with him. So one-to-one daytime carer makes his breakfast, gives his medicine, takes him in the bus to the lakeside, feeds the pigeon, take him to the walk, take him to his daughter's house, back in the evening. Gentleman comfortably living in his own house, not on a single milligram of antipsychotic, and having a better quality of life. So that's the BPST for you. The take-home messages, just a few summaries, shots there. What I would highlight is person-centered care remains integral to the management of BPST. Antipsychotics may have a role, but it is not the first resort. It is the last resort when non-pharmacological strategies have failed. I hope I have been able to take you through this very important area with this most striking patient that helps me to learn about BPST day in, day out, how we should be managing, and the importance of person-centered care. Thank you.